Very good morning to all of you, and welcome to the weekly CME organized by the Candy Society of Medicine. Before going on to that, I would like to make two announcements. On 30th of September, there will be a workshop, capacity building workshop for stroke unit, workshop on stroke unit capacity building for clinicians, organized jointly by the SLMA and the KSM. And this is a WHO sponsored program. Therefore, I think we have limited number, only we can accommodate about 40, and the participant will be given a Peradeniya as well, and some refreshment, a book, very nice book, organized one, and certificate as well. So I think it's important who are interested on this stroke management, who are involved with the stroke management. I urge to register for this workshop, which will be held on 30th of September. And also on 6th of October, the KSM will be having the foundation sessions. We will be having it either as a hybrid or a physical one, depending on the country situation. So we will send the notice and the details as time goes by. So coming back to today's CME lecture, today's resource person is Dr. Saman Nanayakkara, who is a senior lecturer in Anaesthesiology and critical care at Acute University of Peradeniya, teaching hospital Peradeniya as well. He obtained his MBBS in 1995 from Peradeniya, and his postgraduate MD from PJM Colombo in 2009. And he proceeded to Western Australia for his foreign training. Since then, he is working as a consultant attached to the teaching hospital, Peradeniya and university as well. So he is actually the past president of the Sri Lanka Association for SLASP, that is Sri Lanka Association for the Faculty for the Study of Pain, and also he was the head of the Department of Oral and Maxillofacial Surgery in the Faculty of Dental Sciences, as well as later head of the Faculty of Anaesthesiology in Faculty of Medicine. And he's in the College of Anaesthesiologists as internist of Sri Lanka as well. So apart from his academic work, he is involved much in voluntary work. He is the current president of the Sri Lanka, the Cancer Care Society of Peradeniya Dental Hospital. Actually, he has initiated a lot of donations through Rotary, etc., amount to millions actually. So I really appreciate his services apart from academic activities to the society as well. So without taking much time, I would like to invite him to talk on pain, the symptom that is often overlooked. Thank you.
Thank you very much for the introduction, Professor Article, President KSM. So I'm thankful to President KSM and the Council for giving me this opportunity to talk on this all-important topic, pain, the symptom that is often overlooked. So pain, in fact, is the commonest symptom in the world. 20% of the world suffers from chronic pain at any given time. Even right now, 20 to 40% of the world is in some form of pain at any given time. So 20% accounts for chronic pain, and the rest of the 20% for acute pain and subacute pain. So 2/5 of the world is suffering from pain at any given time. Look at the percentage of elderly suffering in pain in US, for instance. The United States, the world's probably the most authoritative country who has authority over entire world, 60 to 80% of their elderly suffer in pain, and half of them are immobile, crippled with pain in elders' homes and hostels. There are many literature supporting this. There are many systematic reviews talking about prevalence and incidence of pain. And this is, I have quoted just this one. So this says hospital-wide pain prevalence range from 37 to 84% in this systematic review. And out of that, severe pain prevalence range from 9 to 36%. Higher prevalence of pain was found for surgical patients compared to medical patients, and even among medical patients, 55% of medical patients reported pain. Well, pain is one of the first symptoms explained by man. So historians and anthropologists have proven beyond doubt that pain is one of the first symptoms that man started complaining about and started looking for answers. And it was pain that led to the development of the discipline called medicine. And it was pain that developed to the development of the discipline called anesthesiology. And it is the same symptom that led to development of the modern, one of the newest disciplines called pain medicine. And pain is the commonest reason to see a doctor, commonest symptom among patients who come to hospital. So I have just quoted one study which says 30% of the patients who were treated at a primary care had some kind of pain. Pain is a pandemic. Pain is a pandemic. It has been a pandemic ever since man has started complaining about things. So it's present in all over the world, rich countries, poor countries, developed countries, developing countries. However, it is commonly overlooked, ignored by doctors, ignored by nurses, and all other healthcare workers. So the WHO has done many publications regarding this pandemic status of pain, and also about the fact that it is heavily overlooked. Nobody takes care of pain except for a few. Pain is a syndrome. It's not just a symptom. Nociception, where the pain story starts at the periphery of the body. So nociception is a local entity. Finally, pain is interpreted by the mind. Pain is a thought. So pain is a systemic syndrome. It affects almost all systems and organs. So ICD-11 classification, International Classification for Diseases, 11th revision, defined pain as a separate disease. Chronic pain as a separate disease. And when we know chronic pain is pain that overlasts primary injury, which led to pain. And generally we call a pain a chronic pain when it has lasted for more than 3 months. Well, medics do not read pain, often overlooked. So this is what I'm emphasizing in this lecture. Hardly assessed formally. So we generally do not follow formal pain assessment forms or charts or anything, that sort of thing. Not even casually, very frequently. Frequently forgotten to check about pain in our ward rounds. So we look into temperature, we look into infection, inflammation, inflammatory markers, other systems, but often pain is overlooked. Sometimes the primary presentation of the patient to the hospital is pain, but still overlooked. For example, a patient who has presented with a fracture neck of femur, some kind of, say, a drip may have been started, referred to orthopedic surgeons, DT done for cross-matching, other basic investigations done, theatre informed, maybe patient needs an HDU bed after surgery, but no analgesics have been given. Same thing about a renal colic. Patient is being prepared for X-ray GUT and treating possible urinary tract infection, but still pain has not been addressed. Maybe one dose of pethidine or morphine has been given at the time of admission. That's it. You look at the drug chart, not many or no regular analgesics on the drug chart. So who forgets to assess pain or who forgets to treat pain? Well, emergency staff forgets, pre-operative staff forgets, post-operative staff forgets, critical care staff forgets. Whether the patient in the critical care staff is either unconscious or deeply sedated, sometimes paralyzed, can't even express compared to other patients. Even anesthetists forget pain. Maternal unit, pain is forgotten. Pediatric wards, medical wards, everywhere. So why do we forget to assess pain or treat pain? So we are distracted by other instabilities of the patient. The patient's blood pressure may be low, or he's dyspneic, or there may be various other things. Well, true enough, we have to attend to those things first. Or maybe we have an excuse saying we are short of staff, or we are not trained to assess pain, or we are not bothered about pain, or we have a opiophobia. We are scared of opioids. So we are the people who are most learned about opioids, but it is us who are most scared about opioids also. So we have various fears for opioids. We have fear of respiratory depression, fear of cardiovascular complications, fear of masking neurological signs, symptoms, fear of addiction to opioids, or we are not concerned about pain, or lack of knowledge about complications of pain, poor working knowledge about pain management, and etc. Okay, so what is the big fuss about pain? Why should we control pain? One thing, on humanitarian grounds, anybody should treat others suffering or try to help anybody who is in pain or suffering. Financial losses, this is something we never consider in our country. So if a patient is in pain and if he's not reporting to work, he's losing money, he's not generating money. He may be the breadwinner of the family and he's not bringing money home. So there's a loss to the family, loss to the patient, loss to the health system. He may be still an inward patient, can't go home because he has pain, or he's being discharged from this hospital and going and seeing another hospital, another doctor in somewhere in another hospital. And finally, there's a big financial loss to the country. And there's another medical reason for treating pain. So pain leads to multiple medical problems. So pain affects all facets of health: physical health, mental health, and social health. So under physical health also, pain will affect all systems: cardiovascular system, respiratory system, gastrointestinal system, genitourinary system, musculoskeletal system. It will increase the stress response to pain. And finally, you will realize pain affects the entirety of a man, the whole man. His physicality, mental status, social health, everything. So to mention briefly, what are the adverse effects of pain on the cardiovascular system? Well, pain can cause tachycardia, raised blood pressure, increases myocardial oxygen consumption, can cause arrhythmias, worsening of cardiac failure, can precipitate ischemic heart disease in a person who is prone. What are the effects of the respiratory system by pain? So pain will reduce depth of breathing, especially if the patient has undergone a procedure or has a trauma or pain in the chest or the abdomen. It will reduce vital capacity, atelectasis, hypoxia, VQ mismatch, reduce cough. If you cough, there's pain. Retention of secretions, finally leading to respiratory tract infections. That will be a pneumonia, which we will never interpret to be caused by pain. Adverse effects of pain on the musculoskeletal system, well, there will be reduced mobilization, deep vein thrombosis, pulmonary embolism, hypostatic pneumonia, pressure sores, muscle wasting, joint stiffness, contractures. Adverse effects of pain on the gastrointestinal system, genitourinary system, where there can be gastritis, peptic ulcers, delays gastric emptying, reduced bowel motility, looking like a paralytic ileus, constipation, and even will lead to urine retention. So in the middle of the night, the house officer may be complain or call to attend to a patient who is in urinary retention, then to see the cause is pain. There are many definitions for pain. The most widely accepted definition is the definition given by the IASP, International Association for the Study of Pain. They had a definition which lasted 40 years unchallenged from 1980 to 2020. After 40 years, they changed the definition. Again, they could change only 5 or 6 words, that's all. Rest is basically the same. So the definition given by IASP about pain speaks volumes about pain. So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we are always talking about tissue damage when it comes to talking about pain. So it's a sensation, unpleasant sensation, and it has an emotional aspect also. Looking at the pain pathway, so at the bottom you have where there's nociception, there's tissue trauma, and the pain messages starts there. We call it transduction. Then the messages enter the dorsal root ganglion of the spinal cord and then crosses to the opposite side of the cord and ascends up in the spinothalamic tract to the thalamus. From the thalamus, there are multiple projections to the frontal cortex, to hypothalamus, to brain stem, and many other places. And finally, pain is interpreted as pain by the mind. Therefore, pain is a thought, and it is coordinated by the brain and the central and peripheral nervous system. So mind is everywhere in the body. Mind is not something that is only in the brain. Now, because of these reasons, the developed world, so they started pain clinics and pain management teams a long time back, well before us. So they have pain specialists, pain fellows, senior registrars, nurses. They have a pain office, separate pain department, all that to combat pain, because it is such a menace, so costly in the developed world. Now, to treat anything, you have to do basic assessment. So how do you assess pain? Well, there are more than 100 methods, charts, tools to assess pain. I'm not going to go into those details. This is just an introduction of those things. So we can divide all those things into two broad categories: subjective pain assessment methods, objective. So subjective methods, you just ask a subjective question from the patient, whether you have pain, if so, how much, mild, moderate, severe. We can call it a verbal rating scale also. Oh, there are formal pain assessment scales, more than 100. A simple tool that can be used as a bedside tool would be NRS, numerical rating scale, where you talk to the patient and say, well, how much of pain do you have? If you have no pain at all, your pain score is 0 out of 10. If you have the maximum pain, think it is 10 out of 10. Where is your pain standing? 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Where is your pain standing? Let's say the patient says, my pain is 9 out of 10. You give a subcut morphine, 2 tablets of paracetamol, diclofenac sodium. After half an hour, you come and ask the patient. Now the patient says, my pain is 2 out of 10. So earlier it was 9 out of 10. Now it is 2 out of 10. So you have measured patient pain objectively. But well, on the other hand, pain is a subjective feeling, and whether you can objectively assess a subjective feeling is a different question. So there are many pain assessment tools. We are not going to go into broad details. So why should we treat pain? Another reason is the patient has presented to the hospital with a primary injury. So the primary injury may be a head injury, spinal cord injury, chest injury, whatever. Maybe a medical disease like pneumonia, burns, or pancreatitis, which is medical or surgical, whatever. And there are many other secondary injuries that can happen in the patient in the hospital. So primary injury you can't prevent; it has already happened. What we can do is treat the primary injury and prevent secondary injuries. So secondary injuries, there are many: hypoxia, hypercarbia, hypotension, infection. Pain is one such secondary injury which can cause many problems, but which is controllable, manageable. Therefore, pain we have to understand as a priority in management of a patient. So stages of pain management. When should we treat pain? At which stage? Extrication from the site of trauma, during transfer to the hospital, in the emergency department, OPD, transfers within the hospital, you are taking the patient to the X-ray, CT scan, ultrasound, and various things. In the ward, in the ICU, during surgery, it's the duty of the anesthetist. So, in summary, pain should be managed in all stages of patient care. Pain is a vital sign: airway, breathing, circulation, disability, and it is the 5th vital sign. So, if you go to the developed world, you will see all nurses in the emergency department, in the surgical department, they all check airway, breathing, circulation, disability. Next is pain. Well, so we have a problem. Problem is pain. What is the answer? So how to treat pain in the hospital setting? Simple answer is multimodal and multidisciplinary approach. What do you mean by multimodal? You try and attack pain using different modes. Multidisciplinary is try to get all disciplines involved: nursing, surgeons, anesthetists, physicians, pediatricians, physiotherapists, junior staff person, everybody. So pain is such a complex phenomenon, multifactorial, many factors affecting pain pathway, complex pathway, multiple neurons, hundreds of synapses, hundreds of neurotransmitters and local hormones. And there are many inputs modifying pain. So there's an individual interpretation. There are psychological interpretations. So such a complex thing obviously cannot be controlled with a single drug. That is why we should have multimodal approach. So at least giving paracetamol and talking to the patient. So talking to the patient and explaining, counseling, pacifying or something, that is the next mode. So when you look at the pain pathway, I showed this slide earlier also. So you know there are different stages. There's transduction, synaptic transmission, central transmission, modulation or inhibition. Well, the brain and the nervous system has a pain inhibitory system. Brain and the CNS has its own opioids. And if not for this endogenous opioid system, we would be dying of pain from the birth to death. It is the descending pain modulation system that is controlling most of our pain, and what is beyond its control only we feel. And then finally, it is the brain and the mind that interprets whether this is painful or not. So how do you treat pain? So EPM, there's a course called EPM. The Anesthesia College is conducting that EPM, Essential Pain Management course, where they talk about RAT, R-A-T, recognizing pain, assessing pain, and treating pain. Very simple things. This was originated in Australia and New Zealand. Very simple approach to control pain. So you have to recognize pain and assess pain. So if there's a patient in the ward or in the clinic, we have to ask whether they are in pain. So the fact that patient is not crying or shouting, not yelling, does not necessarily mean the patient has no pain. We have to ask. Find the cause of pain and treat the cause. Then you have pharmacological management and non-pharmacological management. So find the cause and treating the cause. So I have mentioned a few examples here. So if the patient has an abscess, it has to be drained and antibiotics have to be started. If there's a wound, it has to be cleaned and dressed and antibiotics have to be given. If there's an acute appendicitis, the patient has to undergo appendicectomy. Ovarian cyst, twisted or bleeding or torsion, it has to be attended. Maybe laparoscopically open or whatever. Bowel obstruction, need a laparotomy. So that's a fracture. You need an open reduction. Or dislocation, sorry, one end is missing. You do a reduction of the dislocated joint. So you have to find the cause and treat the cause. That is one of the important things. Then we have pharmacological and non-pharmacological approaches. So under pharmacological approaches, we have many drugs. We have simple analgesics like paracetamol, NSAIDs, simple opioids like tramadol and codeine, strong opioids like morphine, pethidine, fentanyl, local anesthetic agents, which can be used for local anesthesia or for regional anesthesia. Entonox, which is a mixture of 50% oxygen, 50% nitrous oxide, ketamine, many adjuvant drugs like pregabalin, gabapentin, many drugs. And something that all of us forget is non-pharmacological management. So non-pharmacological strategies we generally do not implement because we have forgotten the fact that pain is finally interpreted by the mind and the brain. And we have got away with the idea that pain can be always controlled with drugs. So there are many non-pharmacological strategies which we hardly use. So psychological interventions, explanation, counseling, cognitive approach, relaxation. Now, mind you, there have been filling of infected teeth without giving local anesthesia, only by cognitive approach. A trained psychologist talking to the patient, changing his mindset and changing the patient to believe that there's no pain. So that is cognitive approach. And then they have done the filling, they have shown with totally cognitive behavioral approach. So transcutaneous electrical nerve stimulation, tense acupuncture, hypnosis, splitting, immobilization, massaging, rubbing, hot water bottles, elevation. There are many other things. So to take an example of principles of managing acute pain, well, acute pain could be mild, moderate, severe, excruciating. Consider the injuries, what type of injuries has the patient got, the comorbidities, age, etc. Assess the severity of pain, believe the patient. So sometimes we ask the patient and they'll say, oh, there can't be this much of pain associated with this injury. No, appendicitis can't be this painful. Yesterday I did the patient, 5 patients who had DNCs. They were not shouting like this. Why is this one shouting like this? So ignore less important issues like fear of addiction when it comes to managing the acute pain, So Try to implement multimodal approach. Prompt actions. You have to start pain management now, not by the doctor who is come in the next shift. Adequate doses of correct combination of drugs can reduce drug doses later. So when it comes to managing acute pain, there's a wide range in perception and interpretation of pain. So 5 patients may have undergone the same surgery by the same surgeon, same anesthetist, but they have 5 different. One is shouting, one is crying to herself or himself, one is fast asleep, other person is working on the computer. So they have 5 different ways of interpreting the same tissue injury they have undergone. So when it comes to managing acute pain, if it is severe especially or excruciating, one big rule is we have to get on top of pain, start from the top of the WHO analgesic ladder. So get on top of pain and demolish pain, then start coming down. So start with a good combination of drugs, adequate doses, precise timing. We have many barriers to pain management. Patient barriers, professional barriers, organizational barriers. I think the biggest barrier is the professional barrier, where we believe that patient's pain does not need to be managed, or we believe we cannot control it. Well, we may not be able to treat it totally, we may not be able to cure it, but sometimes some of us believe that pain cannot be controlled, or we are not bothered about that. For instance, you get a post-operative patient or post-trauma victim, we can start the patient on a strong opioid like morphine, 0.1 to 0.2 milligram per kilogram dose. 0.1 for elderly or relatively weak people, 0.2 milligrams per kg for relatively strong young child man. Let's say it's a ruggerite who is after an injury, give a big dose of morphine. Or Peradeniya if morphine is not available. Well, morphine is the better drug, and it is again overlooked, and doctors and nurses both tend to use Peradeniya, which is of much lower quality compared to morphine. So morphine acts for a longer duration of time, Peradeniya 2 to 4 hours, morphine 6 to 8 hours. Better quality of analgesia, so use morphine. And try to combine it with paracetamol or combined drug like paracetamol, codeine, rapidine, or Panadine. NSAIDs, we have non-selective drugs like diclofenac, and we have COX-2 selective drugs like toricoxib and celecoxib, toricoxib 60 BD or celecoxib 100 to 200 BD. Tramadol, local anesthetic agents with a regional block may be fine. So then comes the question of, will they get dreaded complications if we use opioids? Like hypertension, respiratory depression, sedation. Well, if a patient is in severe pain or moderate pain, generally they would not get dreaded complications like those. We have to use strong opioids. So titrate the dose with the patient, looking at the requirement. And so we have the WHO pain ladder. We have a ascending ladder and a descending ladder. So ascending ladder is good for increasing pain, like cancer pain or chronic pain. Slowly, because you can see the patient today, give some drugs, review the patient in a few days or in a week, and you can gradually escalate. Whereas if the patient is in severe pain, like in the trauma unit, emergency department, or post-operative patient, start from the top, use drugs of high intensity, start coming down as the patient's pain is getting controlled. Right. So this is the other question which I want to talk today. So can pain be cured only by drugs? So pain pathway, well, the final destination is the brain, experienced by the mind and interpreted by the mind, mingled with thoughts. It's an unpleasant experience, highly personal. We have different reactions to pain and different interactions from our own with our own mind. There are things called pain behavior, pain suffering, psychological things, social impacts, etc. So such a complex thing. So for instance, take a Hindu devotee who is going in Teru cart, being hung by 6 hooks in the back. He has no pain because of the faith he has towards the God. So he is not interpreting it as pain. And look at people who does Kavadi dancing, walking on fires because of the faith they have towards the God. It's not painful for them, or at least they are not interpreting it as pain. So if a circumcision is being done for religious purposes, so for cultural purposes, it may not be as painful as we think when we do it in a surgical setting. We do not know. And a crying child, put the child to mother's breast, the child becomes silent. So either he does not interpret the painful injury any longer as painful, or there's something is happening. So because of this, considering all these complexities, IASP revised their definition in 2020, and they have given 6 keynotes. And again, these 6 keynotes talks about the complexity of pain. For instance, the first one says pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. The second one says pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Something beyond neurons is happening there. Third one, through their life experiences, individuals learn the concept of pain. Now, do we need to have a new toothache to realize what toothache is? No. We have had it once and we know what it is going to be. And every time we climb to the dental chair, we know whether it is going to be painful or not. Generally, in the military, all soldiers are scared of the dental surgeon more than their enemy, because they know all dental procedures are going to be very, very painful. So a person's report of an experience as pain should be respected. We can't say, no, that can't be painful. So how many times have we heard that? Our senior doctors, colleagues, nurses, midwives telling, no, I have delivered 5 children. It was not painful. How can this woman shout like this? So it was not painful to her, but it's painful to this person. So we are overlooking, pain is overlooked there. So although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. And last thing is again very important, verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences pain. Well, there are psychological interventions because this is something that we always ignore. We never address that. What are the psychological approaches that can be used to control pain? Explanation. Just say, okay, don't worry, this is cellulitis, and we have started you on strong antibiotics. We are giving you saline. We are keeping your leg elevated. Your diabetes has to be controlled in 2 days. These symptoms will be getting at least getting controlled to a good degree, and you need antibiotics for 1 week or something. Don't worry, you will get better or something. So that kind of explanation, reassurance, love, care, respect, relaxation, meditation, religious faith. Using religious, we can make use of the religious faith that the patient is believing in. We don't have to believe in that, but we can make use of that. If the patient is believing in God, we can use that God concept to help him to take up pain. Counseling, mindfulness, concentration or distraction, cognitive behavioral therapy, hypnosis, breathing exercise, happiness, mood elevation, antidepressants, anxiolysis, all these things can be utilized to control pain. And these are used to control pain at the brain level or at the mind level. So non-pharmacological pain control therapy, there are many other methods. Comfort therapy, so giving the patient a comfortable chair, bed rest, breathing exercises, heat therapy, cold therapy, massaging, rubbing, gels, lotions, music, art or drama therapy, mobilization. So doing physiotherapy or resting, whatever, manipulation, positioning, turning, elevation of, let's say the patient has a fracture in the forearm, so just letting it hang versus having a collar and cuff. Patient is having a problem in the calf, let's say the patient has a fracture tibia fibula, keeping the leg flat on the bed versus keeping the legs elevated on 2 pillows after surgery. Bed bath by the nurses, making the bed comfortable, all that matters. Many other things. Culinary therapy, aromatherapy, physical therapy, physiotherapy, exercises, acupuncture, neurostimulation, spinal cord stimulation, neurosis, radiation, surgery, chemotherapy. I'm just giving a list of things that we never think of. And it's high time we think of those things. Well, now, what prevents us from practicing non-pharmacological management? One thing, we do not consider it as a need. We think we can control pain solely by drugs. And pain medicine is not a specialty. We manage pain while doing many other things. It's not a specialty. I'm talking about this country. It's not. We have 2 posts, one at NHSL and one at NHS Colombo and Maharagama. Health Ministry finally has appointed 2 anesthesia consultants to work as pain specialists. And even when we manage pain, it's not truly multidisciplinary. No counseling, no psychology. Do we allow hypnotists to come and work here? Do we allow meditation instructors to come here? No. In the US, UK, France, Germany, Japan, New Zealand, Australia, they do allow. in the chronic pain clinic, you can see many other people. So the Western world, the developed world, and there has to be a reason when we call them developed. So they have a reason. So they have understood the limitations of Western medicine. They have only about 15 to 20 drugs to be used for chronic pain. And once those are finished, so we have only about 5 or 6: gabapentin, pregabalin, carbamazepine, tramadol, and a few other drugs. Once those are used, it's finished. So now they have looked for other avenues and finally found what was earlier labeled as rubbish and ignored as primitive medicine has now been brought and given a place on the stage and called complementary medicine or alternative medicine. So anything outside Western medicine is called alternative medicine. So that has a place even in a chronic pain clinic in New York, in London. And we have no proper place to work, makeshift clinic. So I have a chronic pain clinic at Peradeniya done in the gynecology clinic. So on the days that gynecologists are not there, my pain MO is here. So we can do a clinic on the days that the gynecologist. So we have no place to develop a specialty. Although we are interested, we can't. We have no place, physical place. Tiny little hospital, Peradeniya, not like this giant majestic hospital. We have only 2 stories. And we don't assess pain properly. So we can't treat properly. So bradycardia can be treated only if you have measured the heart rate. Respiratory depression can be treated only if you have measured the oxygen saturation, the respiratory rate, and things like that. But if you do not assess pain, how can you treat pain? So we need to think of assessing pain quickly. Now we don't need 5 minutes to assess pain. 10 seconds is enough. Ask the patient, do you have pain? If so, how much? Or from a learned person, educated person, you can ask how much is it out of 10. Well, I'm coming to the last 2 slides. So we always have an individualistic approach. We are really compartmentalized. Especially in Western medicine, we are, I think, over compartmentalized. We have so many specialties, super specialties, subspecialties, not with much integration. We are moving forward very fast, but leaving aside morality. Holistic approach is forgotten. Technologically, we are very well advanced. We can do in utero surgeries and all kinds of things, but we are not addressing spirituality. Ethical aspects we have forgotten. How rough are the health workers, especially in Sri Lankan setup. So the Western world, they have gone very far. And so when it comes to pain management, at least talking to the patient in a proper manner, recognizing his and respecting the patient, and talking to the patient softly, sharing his thoughts, sharing his difficulties with him will take a long way. Spend 30 seconds for that. 1 minute maximally. I'm not asking doctor listening to this to spend half an hour with the patient like that. So way forward, include pain into medical and nursing curricula. We basically have done that. Now in all medical schools, we have lectures on pain. When we were medical students, we did not have anything on pain. We don't have any teaching. Now there's even a final year appointment on pain medicine. Well, anesthesiology appointment is there. There's pain medicine taught within that specialty. So continuous medical education like what we do here today by the KSM is essential. Removing barriers. So as I mentioned, the biggest barrier is inside our own mind and brain. Then implementation of pain medicine by authority. So the hospital, so our director general, deputy director generals, hospital directors, they should recognize pain as a need. So for instance, in most of the hospitals, when we meet in anesthesiology sessions, we discuss in most of the hospitals, there are enough space, ample space for anything, but there's no pain for a pain clinic. So at Peradeniya, I have photographs in my nurses and doctors have collected doing nerve blocks on the corridor, in the stairwell, all kinds of places. We have in front of the theater, or just outside the ICU. We have no proper place. And we need to integrate with other disciplines, traditional medicines, homeopathy, acupuncture. So we have to break that voodoo and barrier and let them join us at some stage. I'll stop there. Thank you, KSM, and thank you for listening. I think, yeah, I took 40 minutes this way. Thank you very much for listening. If you have any questions, I can ask.
I have a question. So the assessing the pain in other countries when it comes to emergency department, so they ask the patient what is the pain score out of 10.
Yeah.
I should practice in our emergency department. The problem is some of the general population they are not aware, so there's a big barrier teaching. How should we overcome that? Any ideas to assess that patient, acute pain especially?
I think we have to gradually introduce it to our population. So learned people, educated people can give an answer. They can give a number out of 10. And the developed world patients, I think, have been exposed to those questions for some time. So they are quite used to it. Even a school child will give a number for his pain easily. And our people might not do that. And some probably do not know numerical, not good in mathematics. So haven't learned things like that or whatever. So maybe difficult, as you said, we are experiencing that practice. At least we can ask mild, moderate, severe, associative pain or something like that. At least to start with, we can gradually introduce it to other pains. But if you realize chronic pain patients, they can give that answer. So even in lots of chronic pain clinics, we straight away ask the number. Even at Peradeniya, we ask what their pain is out of 10. They can give a number. So a trigeminal neuralgia patient will easily give a number. Is that a question? Yeah.
I want to ask you the preoperative clinics. We have preoperative clinics for anesthesia before the surgery. So when you go for that also in that form, there is no teaching for the patient about a visual analog score of pain or a numerical score of pain. So I think from the anesthesia point of view, I have seen that chart, basic the heart, respiratory, the physical, but pain there's nothing.
Yeah, so he's correct. So I mentioned anesthetists also in the list where in the list where who is not attending to pain. So anesthetists are also one group who is not attending to pain. So anesthetists should take the leadership and initiative. However, it is sad that it is not happening even among anesthetists very frequently. So there are people who are very interested in it, but as he suggested, when we see patients in the preoperative setting by the anesthetists or the ward officers or SHO, whoever, we can tell the patient, well, there can be pain after surgery, but don't worry, we will look after that. We will address your pain. We will give pain medicines and all that. And you can ask for more medicine. If you still have pain, you can ask for an injection. We can give it there. We can pass a rectal suppository. You can have breakthrough oral medication. So we can give you a patient control analgesia pump. We can put you on a regional block. So all kinds of things we have to educate. It wouldn't take time. It will take 1 minute or 1.5 minutes. That's all. But we have found a good excuse. That is to say, we have no time. We can't say we have no 1.5 minutes to talk to a patient.
The patient doesn't know that there are such things when they come.
Exactly. Now, especially in the Sri Lankan context, now we have a belief that pain is part of our suffering. Especially Buddhists and Hindus believe that it is part of their suffering. Now, when it comes to the Christian world, the Western world, European type lifestyle, where even US is not Europe, and New Zealand, Australia. So nobody wants to be in pain just because of the faith they have towards the God. Faith towards God is different, but they don't want to be in pain. So living is being free from pain, free from suffering. Whereas in Buddhism, suffering is an integral part of living. So Buddhists interpret being born as a suffering. Living is also a suffering. Dying is also a hell of a suffering. And so everything is suffering according to Buddhism. So Buddhists believe, and so similarly, there's a degree of similar thinking in Hinduism also. So pain and suffering is part of our life. So a lot of people, in a way, that is very good also. So that has helped our way. Now, so one big problem that the Westerners are having, Western pain is having, the patients demand and to do various kinds of things and relieve pain, which they cannot do. So they have used all the medications they know, all the medications that are available under the sun, but still the patient is in pain. So they don't want to accept pain because for them, their lifestyle is such. Living is being free from pain, no suffering, drinking, dancing, going on to go for parties, hobbies, going to the beach, going to the cinema, sex, smoking. Everybody is not smoking, but enjoying life is all about in that lifestyle. And for us, it is a suffering. And so a lot of people in this part of the world believe, oh, so we will what to do. This is part of our life, so we have to undergo this. So that probably is what has saved us, because we are not practicing pain medicine a lot, but they are thanks to their belief system, we can get away.
Thank you, Dr. Nanayakkara.
Thank you very much.
One situation where there was several instances where for chronic pain when we used morphine, some patients try to treat it, but they are acting or sort of to get more and more of that, they are acting as having pain. So in such situations, what should be there?
Yeah, so that I think is a very difficult situation. If once you get a patient who is addicted to morphine, it's a difficult patient to handle. So in the developed world, tackling opioid addiction, they have different pathways, and still they also haven't found issues. You know, various celebrities have also died of opioid addiction. When it comes to our setup, so still sizable number of patients respond to placebos, and sometimes it is difficult to fool drug addicts, but distilled injections, whether it is ethical or not, I do not know. Placebo tablets have sometimes worked, but it is a difficult entity. Patient coming and complaining that is a patient with chronic pancreatitis, so cholecystitis, and PVD patients. On the other hand, they may be having a degree of pain truly. We always say that they are addicted and they are asking for pain relief. Thank you very much.
Thank you very much, sir. Thank you very much for that very informative lecture. And you have taught us the pain is not merely a managing, giving analgesics, and it is some psychological as well, and also the physiological and physical. So in the absence of any other question, the small make another notice that the 20th workshop on neurology, so stroke workshop on 30th of September, workshop on stroke. That is very useful lecture and the certificate course, which is funded by WHO and will be given a very good certificate. But the only issue is only limited numbers are allowed, only 30 participants, so please 40. So please make sure that your participation is ensured through the KSM office. And the interesting thing, they usually we charge from you, and this time they will pay for you for the participation. So please participate. It's on 30th. And I cordially invite Dr. Senior Consultant Dr. Arambe Puller to hand over certificate of appreciation to Dr. Saman Nanayakkara. And the other thing, there's a neurology workshop we scheduled last month, but because of the current situation, and which will be held in next month, and we'll inform you. And thank you very much for all the participants physically and also the online. And also the special thanks goes to today's sponsors, Abbott Laboratories. Thank you very much. And keep in touch with us. And another note, I think KSM will make a platform to develop this pain syndrome. This is the syndrome in the sense, what I mean is not only the treating, but the psychological aspect also. So we'll try to make a platform for user. So we'll have a better discussion. Thank you very much. Sorry, your refreshment will be provided on the other side of the room. Please take your refreshment.